years, both within the Patient Safety Translational Research Centre and on quite a landmark programme grant looking at transitions of care. However, with somebody that talented, he moved on and he went to the University of York and now at London South Bank University. So Tom looks particularly at implementation issues in his work, and it's his wonderful work around broadening our understanding of implementation and the support that logic models can have for the wider context in which interventions need to be considered and delivered. So I'm going to hand over to Tom, who I'm sure will do a more comprehensive introduction of his work. So thank you very much, Tom, for joining us today.
Well, thanks, Beth, and that's a really nice introduction. And they're really good days at the Yorkshire and Humber PSTRC. So I really enjoyed it. I understand the acronym's changed now. I'm just catching up with Lauren earlier that it's now a PSRC, and
yeah, we've lost a T.
Yeah, yeah. And it's, yeah, you do a better job at describing my work than I do, I think. But hopefully I can provide a bit more, flesh it out a little bit more. But yeah, really happy to be here, and thanks for the invite. Yeah, so I'm going to be focusing on the logic model aspect of my work today, and yeah, it's something that I never planned for logic models to be a central feature of my work. It's something that's just kind of happened by accident, but it's actually been really integral to my work over the past 7 years. I'm just going to share my screen briefly. So this not necessarily shameless self-promotion, but a lot of what I'll be talking about in this presentation is set out in this paper that I published while I was working with you on, called the logic of logic models. But for a kind of dry academic paper that no one reads, it tells a really quite personal story, really, kind of on the first exercise in logic modeling. And so I finished my PhD at the University of Westminster in 2016, and that was, I was in the politics department. I did NHS policy stuff, and I didn't really know what to do, but I did some qualitative research in health service context, and the job came up, and it looked amazing. So I moved up to Bradford, and I was working doing an evaluation of a complex intervention. But just then getting quite frustrated with the logic model paradigm. And of course, early career researcher, what do? You blame yourself, right? That you're the problem, not the paradigm. And but then the other thing that you do, you start asking colleagues, well, you know, how should I be doing this? And I kind of went around the organisation. I was getting really good advice on how to do logic models, and I was getting different sets of advice of how to do logic models. So I was getting exposed to, didn't realise at the time, but I was getting exposed to very different approaches that you can take to create a logic model. And so I was kind of satisfied. This would satisfy me a little bit for a couple of weeks, but then I'd get increasingly frustrated. The intervention that I was looking at was just adapting in all really interesting ways. It was a ward level intervention, and different wards were doing different things, but of course with a very linear logic model, it was just pushing that linear kind of structure to yeah, it just wasn't fitting, wasn't able to accommodate the complexity that I was observing. And so that really was the focus of the paper, is really my frustrations, because I was trying different approaches out, and finding them in different ways quite wanting, but then also after quite a bit of work on how a logic model, what kind of logic model template would actually fit the complexity of the intervention, I set out an alternative approach. But it's a really personal story, and I really appreciate the time, because Rebecca and it wasn't the core part of my job role, so Rebecca and Laura really supported me and understood that I just had this kind of research question that was hovering over, and for a couple of years it was just kind of every Friday afternoon I was just kind of exploring logic models, and that kind of exploration is just told in this paper, and it provides much of the basis of what we're talking about today. Okay, so title of this presentation is Logic Models Developing Theories of Change for the Real World. Yes, so I'm Tom. I'm actually working in public health now, so I've changed acronym to the first centres. That's Public Health Intervention Responsive Studies Teams, and we work with local authorities to we've co-produced evaluations of really quite interesting local authority-based public health interventions, and we evaluate them. The aim is to both improve local decision making, but also extrapolate wider learning for public health more broadly. And again, logic models are actually a really key feature of that. So we really work through with the local partner what their intervention is, and we develop evaluations based on the logic model. So again, it's a really key feature of this work. So with this all this talk of logic models, it's probably worth thinking about what they actually are. So logic models are a central feature of intervention research. So whether in public health, health services research, quality improvement, service improvement, a core part of what we do. It's not the only part, but a core part of what we do is thinking of ways of how we might improve service, some aspect of health service performance or health and well-being. And what we do is kind of design interventions that can be evaluated with potential for scale up. And logic models are obviously a key part of that. I've got kind of the basic template there. Really key being really quite a simple way to think through the logic of an intervention, thinking about the outcomes, really what you're trying to achieve, the more measurable kind of outputs that might lead to those outcomes. I just use an example off the top of my head. I'm working with a stop smoking service, for example, and that they're trying to obviously improve health and well-being, but their key thing is to reduce smoking related mortality. Obviously a key output related to that might be successful quit attempts, and then obviously the activities is actually what they do as a core service. So the treatment and counselling they provide, the provision of NRTs, to telephone delivery, to try and make it more flexible and stuff like that. So really kind of unpicking, well, these are the activities we do, we think these are the outputs, and those outputs lead to the outcomes. And obviously the inputs as well. So often that might include the staff, the resource that's being put in for particular patient groups and so on. So that kind of if-then logic being really important to that, and there being utility in the simplicity of this. So in my work with local authorities, it's just a really useful exercise because we're detached as an evaluation team. We're working with local authorities that obviously know their service, they're delivering. They know the logic of what they're trying to do, but haven't necessarily thought, well, what we're really trying to achieve, and how are we doing to, what steps are we doing to achieve that? So we can kind of tease out their implicit theory of change using this template, and then enables us as the external evaluation team to start developing an evaluation design, thinking about possible measures for an evaluation, thinking about aspects that we don't really know, perhaps there's focus for more qualitative research to really understand a part of the service, and we certainly find it being a really useful exercise, particularly in the early stages of the research. But there are some logic model horror stories as well. So I've been kind of presenting on logic models for quite some time now, and very often I present, and either during the presentation or sometimes after I presented, people will come up and say, yeah, I really agree with what you're saying, and then they proceed to provide me with a horror story of a logic model. And so some of what I'm going to be talking about now is that there's research on this, but that some of this is also anecdotal stories that I've been told. So one horror story is that the all-pervasive nature of the logic model, that they're everywhere, that funders are demanding them, even when there's not an intervention there. The research question might be, I'm going to find out what this patient group think of this. There's no intervention, but the funder says, well, where's your logic model? So that being a bit of horror story. There's also this sense, and I started on this, that actually it's quite a simplistic paradigm. And when you have a complex intervention, that actually they can't accommodate this. So something about not accommodating the complexity of an intervention, but also the context of delivery. And this is picked up by people like Penny Hoare, and the kind of advanced understanding of complex interventions is involving adaptive components, there being a functional forms, a core and periphery, and so on. Well, this kind of almost pushes the logic model template, arguably, to its limits, because you're dealing with quite a linear structure, when actually these more complex interventions are quite adaptive. So with some of the work that I did, and Beth mentioned before, the PACT program, that was patient safety, ward level intervention. Well, actually, there was multiple components to that, and there was a lot of complexity, because you're trying to improve service being delivered to patients, and staff. Staff will be a key part of that, because they are interacting with patients, but you've also got to train and motivate the staff to do that. So there's a training component, which in some ways you might be able to bracket off and just call that the implementation strategy, as something entirely different to the intervention. But that's often doesn't quite make sense, because actually it can be really quite central to the projects, and often it's not the case that you deliver a bit of training and then there's a nice linear trajectory to that. Then the staff would do what they do, change what they do to with patients. Often you have to find kind of feedback as part of you have to look at the impact of the intervention, and use that, bring feedback on the patient experience, on how they found the intervention back to staff. So it's not a kind of linear trajectory, but also, of course, every ward is very different, and you have to adapt to that. Every staff group is different, every patient group is different, and so this is a kind of a level of complexity that's really important to emphasize and make sure you adapt to. But obviously that linear logic model structure, that you risk really obscuring that level of complexity. So there's the argument there that it has kind of analytical weakness, that you could end up kind of obscuring what needs to be done, and also practical weaknesses. So actually, how to go onto a ward and talk and engage staff, or talk with patients, find out what their preferences are. This is a lot real kind of practical stuff, which isn't really captured in the typical logic models. And then there's political problems. So these are some of the horror stories that people have told me along the way, whereby logic models are used, can lend themselves to be used in quite a top-down way. So one service provider talked about how that their commissioner had basically performance managed them, because they had a through a logic model. So they had the logic model which showed, well, these outcomes are achievable if we put these inputs in. If we put this inputs in terms of the funding and the resources are there in terms of the staff, then we should be able to see these outcomes. We're not seeing them, and therefore you as a service, you must not be working hard enough or doing things correctly. And so the commissioner was using a logic model in this really kind of top-down way. And their argument was, well, a lot of peripheral services have been cut that we were kind of relying on for inputs, and with those no longer there, it's a lot more difficult for us to deliver our core service. But of course, none of that context is captured in the typical logic model, and it's some of these kind of weaknesses that I've tried to kind of really focus on and develop. Okay, so are we getting to the limits of logic models? And this was a really nice little logic model that Lisa McNally did, and it was going around on Twitter at the time I did the logic of logic models table paper, and I just had to include it because it's really good. So the inputs: money and time, blind faith. The activities: buy lots of flip charts and sticky notes, hold lots of meetings and workshops, ignore basic principles of causation, lots of logic models as being an output, a simplistic view of reality, outcomes: no money left, no improvement in outcomes, no understanding of WTF happened. Now, I definitely don't condone using the WTF acronym and any circumstances in a otherwise acronym heavy NHS. But there is something definitely here. But for me, it was, let's not throw the baby out with the bathwater. We're trying to represent in diagrammatical form roughly what the intervention's doing. Let's try and develop that and give a bit more accurate reflection of what's happening. Okay, so I'm going to use two cases here to demonstrate the approach I've been developing. So I'm calling this real world logic modeling. So the first case is a participatory research project. The second case is a public policy implementation project. Okay, so this is the case that's actually covered in the logic models paper, and it was an NHR funded patient experience project that was exploring how to use patient experience data in ward level service improvement. So at the time, the NHS had put a lot of emphasis on collecting data, patient experience data, things like the Friends and Family test, but actually concrete questions about how that might be used in ward level service improvement weren't necessarily explored. So this was a major project, multiple work packages. Part of those work packages were exploring the current state of play in terms of how trusts are using patient experience data. But I joined this project at the intervention stage, and the intervention was called the Yorkshire PET, that's the Patient Experience Toolkit. And this was a toolkit for enhancing patient experience, which was being tested across 6 very diverse hospital wards, and there was also 3 different hospitals involved. And that toolkit is in the centre, and it's such an interesting document. It just contains really interesting nuggets of insight in terms of actually how to improve patient experience at ward level. So I do recommend that. But this was participatory research. So this Yorkshire PET was being really developed and refined through this evaluation. It was co-production involving ward staff, PPI reps who had a really key role in this, going on to the wards, talking to patients, and then the research team. So I was the evaluator, but members of the research team were facilitators. So they had a really prominent role in making it happen on the wards, and in taking ward teams through the steps of the toolkit, and I developed a real world logic model as part of the qualitative process evaluation. And there was a lot of data on this, and again, it was very exploratory research. Collecting as much data. I tried to collect as much data as possible, very much in the Laura Shared School, who was my manager at the time, and I learned so much from her. But carrying out observations, we had a survey going on across the wards with a measure of patient experience, but that meant myself and various other research nurses, we were on the wards once a week, collecting survey data, but also doing observations. What was happening on the ward, how was what the intervention activities that could we see, what was the impact, and so on. Or really making every contact count. Interviews at mid and end points with key people involved, both the facilitators, because they were critical, but the ward managers, the ward teams, and the patient PPI reps. And that mid and end was important too, because it was such a messy participatory research project, and understanding changed of what the intervention was about changed along the way. And also facilitated reflective diaries, so they in their key role, and that was more about kind of capturing some of their quality. We had the quantity of the observations, but I wanted them to have a diary just to capture really insightful comments. So that's how it was set up, and this was really the story. So right, I'm going to do a logic model, never done it before, and I forgot about this slide. So this, when it worked, it really worked. And so here's just a picture of one of the wards. In there's the ward team members, the research team, the ward manager, PPI reps coming together, thinking about what the patient experience issues are on that ward, thinking about ways to actually improve patient experience. There was I'll give you an example. One ward had identified loneliness as being a key thing. Care was really good. The service was excellent, but people were just a bit lonely. And so what the staff did as part of this was to implement communal meals, and that just really positive example of the use of the toolkit in that ward, and that photo is a reflection of that. Okay, so thinking about the logic model, I've retrospectively done this because as I was going, that the logic models were a lot more complicated. But this is the most basic logic model, just to give you a sense of the process that I went through. So the inputs, obviously the toolkit, the ward staff, facilitator time and expertise, the PPI rep insights, what they were doing, they were collaborating. Actually, they didn't find the friends and family test data very good at the ward level. It wasn't timely enough, wasn't detailed enough. So actually what they did was gather feedback. The PPI rep went and chatted to patients, talked about how you're finding your experience on the ward. Then there was a kind of process of a prioritization. We've identified these issues, what we're going to do, those changes, making the changes, reviewing them, and part of it was about integrating QI at that level. So some of the outputs, one of the aims was really to embed that PPI rep on the ward, so they really developed relationships with ward staff, and were a key feature. Through the process, both the PPI rep and the staff were enhancing their quality improvement skills. There was new connections, and that was both at the ward level but across the organisation, with a view to that kind of gradually improving patient experience, with ultimately these PDSI cycles actually getting embedded on the wards. So this was the aim was to ultimately to have kind of sustained improvements to patient experience. So the key assumption with this is, successful use of the Yorkshire PEP will drive improvements in patient experience. And at its most basic, that that's the kind of logic model that we might do for this intervention. But the problem was there was a lot more complexity underpinning this. So across the 6 wards, one of the major issues was, of course, some wards were really conducive to this type of work. Some wards were not. There was some wards with I'd say catastrophic staff and service pressures that made it impossible for staff to have any time to step away and to engage in a participatory project of this nature that took their time. And one ward had to pull out altogether because of that. But there was also other factors that meant some wards did okay. Other wards really succeeded, but there was variation there. So my first thing was, well, how do I start capturing that variation? And this is quite an established approach. Actually, you can include a column of moderators here. So these are effectively barriers enablers that are experienced differently across the different wards. And I've distinguished them both at the inner level of the ward, so factors that are internal to the ward setting, but then also the outer, so factors at the trust level or beyond that, so the policy level that are exerting influence on the ward level. So these are factors that really shaped progress. So one ward leadership. So if you started a project and the ward manager was really behind you and was really supportive and opened the door and arranged staff meetings, etc., well, that really helped, right? That was a really key enabler. But likewise, if the ward manager hadn't heard of you or was not very keen on having a quality improvement project going on, perhaps because those staff and service pressures I mentioned, well, that was a constraint on what you could achieve. And that was the same through that. So staff morale and engagement, where staff were really engaged, great, let's go with this. But that could be a barrier elsewhere. And likewise, the hospital level, trust data systems, in some trusts it was really easy to get patient experience feedback, other trusts really difficult. And that was all part of that gathering of data. It meant some wards you could really do it, some wards you couldn't do it. And so here, including that column, you're getting a more nuanced theory of change. It's the successful use of the Yorkshire PET will drive improvements in patient experience, provided that, and then you can enter in the different types of moderator, provided that you have support from your local ward manager, or provided that staff resources are such that staff have the time to actually spend do some quality improvement, step away from the core job task and do some quality improvement with you. So you're getting a more nuanced theory of change with this approach. But even at the halfway point, even this just wasn't doing it, and this is where I was getting more frustrated. And I think the reason for that was first of all, the toolkit wasn't really doing anything. The toolkit is full of really interesting nuggets of information, as I've said, but actually the toolkit was just put on people's desks. It wasn't a live thing that was moving things along. What was moving things along was the facilitator time and expertise. So this is members of the research team who are going on the wards, who are really being proactive and trying to make things happen, and taking staff through the steps of the toolkit. And actually, it was to an extent that perhaps it's not just an input actually there. This is more really central to what they're doing. It's partly around that, but also what they were doing, not only taking the ward staff through the toolkit, but actually they were working to shape the context. And it's this issue here that really shows that we need a different approach. The facilitator time, the facilitators, for example, when they were coming up to one of the moderators, these moderators weren't just experienced, well, this is an enabler. Well, that's great. Oh, it's a barrier. Okay, well, we can't work here, so we will we'll pack our bags and we'll go away. It wasn't like that. They were being experienced in those settings where the ward manager was really supportive. Well, that was a resource that they could draw on, and they drew upon that resource. But where the ward manager wasn't necessarily supporting them, that wasn't just experienced as a barrier. They would get around that. They would find someone, a staff member, who was really supportive, who wanted to be involved and who wanted to lead. So they were really creative in that, in terms of actually coming up, experiencing these moderators, but then also getting around them if they were a barrier. So staff engagement is really important here. So some of the wards, there was very low staff engagement. So again, the facilitators didn't just experience that and say, okay, we'll pack our bags, we can't work here. What they did was do a lot to work with staff to improve their engagement. And one of the things they did was celebrate the successes. So a lot of the data that they were able to get was really positive about the patient journey, really positive about the quality of the staff. But actually, staff at that ward level hadn't heard about that. They hadn't heard that feedback, and it hadn't been. It was just being collected by the trust, but they weren't aware of this. They might have had people sending some cards up. They might have that as on their ward, but they weren't aware that there was all this data that was probably 90% of it very, very positive. And so what the facilitators did was highlight that, and they had celebration of success events to highlight really good aspects of practice. And that was really important, because that got actually staff okay, improve their engagement, improve their actually, yeah, we are delivering a good service, and actually we can work with you, we can do this this project. So that's a really good example there, where staff engagement wasn't just experienced as a barrier there, but actually was actively worked upon. So that implies different types of activity. So that celebration of successes, for example, that is an activity that isn't captured in that activity section. But also improved staff engagement, that isn't encountered in the outputs or the outcomes, because this is more of a peripheral thing. It's only relevant to do that celebration of successes where that is required here, where that staff engagement needs to be worked on. So this is something quite peripheral to the actual core intervention. And again, that then leads to those different types of outcomes that aren't captured here, staff engagement, which in turn create a more conducive environment for the intervention to be delivered. So it's a level of kind of complexity that again, even with the moderator column, is pushing it to its limits. So after about 6 months of playing with the paradigm, this is the kind of template I came up with, and we propose it as a template for these kind of very complex interventions. That yes, there is a core process, there is a core toolkit, there's core features of that: coaching, feedback, participation, so on, and there is a core kind of process in terms of outputs and outcomes that are aiming for that improved patient experience, getting patient reps embedded on wards, completing PDSA cycles. That is kind of all core part of this intervention. But there's a whole lot of other stuff around it, work by the facilitators to improve the context, to engage staff, to form a really cohesive ward team at the local level, or indeed across the hospital trust level. So some trusts, some corporate staff were really supportive, and that was really helpful. In other trusts, they weren't so supportive. So that again, the facilitators would get around that. They would work around at the hospital level. They would find someone who's interested in patient experience and able to give them more support, able to open doors if they wanted a bit of resource, or that they wanted some data, or they wanted some doing. And it's all of that stuff that I've tried to capture here. So actually this intervention is a facilitation intervention, and it actually evolved after this evaluation to become a training package for training people in trusts to be facilitators, to actually be that facilitator who is going to go on the wards and to work with wards teams to improve patient experience. And what they do, they're part of that two-way then. What they've got to do is really flex and adapt to the core ward team. So some ward managers really did do a lot in terms of implementing the toolkit, and that's great. So the facilitation there can really adapt to that. They can be more in the background, supportive. In some settings where the ward manager wasn't so taking on such a forward role, well, actually the facilitation there needs to really step in and come in there. And they've got to take into account the key features of context, all these factors. So at the hospital level, I've mentioned data systems there. So they've got to be thinking, well, what's the quality of the data system here? How might I be getting data? And likewise, at the lower level, at the ward level, all these factors were those moderators that need to be taken into account really when you're going onto a ward. To what extent is there collaborative and supportive ward level leadership, for example? If it's not so apparent, what might we do? How might we kind of recruit people that are really going to interested at that ward level and interested in supporting this? I talked about staff engagement there. So where that's low, for example, well, we need to get data in to really celebrate those successes to work on that, and in that way. You get these peripheral outcomes in terms of heightened staff engagement, which in turn enable you to actually start thinking about doing that core work of the toolkit in terms of actually working out ways to improve patient experience. So it's a lot of context there to this. I've got the core toolkit process in there, but I've got also the kind of key features of context there that really need to be taken into account when a facilitator is going to try and deliver this. And obviously another key one at the top there being resources, so staff capacity to engage in improvement, being a further key one. So the kind of theory of change this leads to, again, it's far more nuanced. So the successful use of the Yorkshire PEP will drive improvements in patient experience with context sensitive facilitation. So it's hitting home that point that facilitator needs to be really thinking about the ward setting and really adapting what they do each time that they deliver the toolkit. I just wanted to share with you a bit of data. So all the aspects of the model are there's data underpinning them. But this was just a little bit of data from one of the facilitators' reflective diary, and this was one of the wards that had to pull out. So again, this data is, I really wanted to use that reflective diary to capture really quality. My advice to the facilitator was, if you have a light bulb moment, or you get really frustrated, or you really want to convey something, use that facilitator's reflective diary to really talk about something that's really key to this. And they were just talking about here examples of the staff and service pressures. So they kept on letting off steam about really emotional and high intensity situations they are finding themselves in, not being able to meet all patients' needs, the strain on staff that implies, and they're also talking about the impact on them as a facilitator. Still has a profound effect on me. Cannot help thinking that the urgency of the situation needs discussing and not dismissing. Is it a patient experience project appropriate when there are such pressing demands? Or do we all need to lobby to try and erase the profile of the situation? And I think that's really interesting there. It's not only talking about that issue of the pressures on staff, but it's, for me, when I'm looking at this and creating these models, I'm also thinking about what level to describe what is happening. So it was clear that actually this is something that's happening quite external. The resource issues, staff capacity to engage in improvement is actually quite external. And what was interesting was that the facilitation team were really doing their best to work across the trust level to try and get more staff resource in at the trust level. So they were asking, you know, we've got this research project. We currently don't have sufficient staff numbers on this ward, but we would like to explore whether we can get some more staff on the ward, and that wasn't possible. So it's kind of telling me that resource issue at the top there is really significant, but it's also something that's happened almost external to the trust setting, that they weren't actually able to influence, working across wards and across trusts. So I thought I'd just kind of share that with you, because it's an example of some of the data that is kind of underpinning this. Does anyone have any questions on that case before I get to the second one? Oh, Beth, sorry, I missed you.
It was just a quick question really about the, so did you develop the logic model as a result of looking at all the data points that you had, or did you have that logic model before you tried to introduce the intervention? So if you see that you looked at the facilitator diaries and then you were able to then add to the logic model, but I think that staff resources is a key issue. So I mean, I'm just thinking about people who are trying to practically implement interventions into a healthcare environment.
So this was participatory research project, and it was that kind of formative action research. So they had an idea of how it would work, but that idea was very much developing, and the process evaluation was alongside and running really concurrently. So the idea of what it would entail was unfolding, and I was kind of adapting the logic model as we went through this process, and I think, so I'm getting all different bits of data and adapting the logic model as I'm going. So I think it's about using the logic model to go into a participatory research project where the intervention isn't really thought out. It's developing in real time in that very formative way, but using the logic model to kind of extrapolate out of that a meaningful intervention. But here it's all happening concurrently. The data collection and working with the logic model to kind of trying to capture what the data is saying.
Yeah. So I guess at some level that you would have one which was for this intervention, but it would have to change in every single environment that you put it into, wouldn't it? So I mean, there might be some universal themes, you know, like staff resources that are going to be true for everybody, but I suppose that in each environment, eventually you would have your own model for every different context.
The precise journey that each ward will take, it really differs, but it's about that embracing that diversity of journeys. It's a complex activity, I think, to deliver the toolkit to each context. So I think it is capturing the broad themes of how this is working, but leaving it open to future facilitators to really adapt it, and hopefully that that diagram of that captures the kind of key themes, I think, around what is significant locally that you need to take into account, or what is the significant factors at the more macro level that you need to take and adapt your approach. And that might be adapting your approach in terms of, well, let's celebrate successes, but it might also be a decision, well, actually this ward, there just isn't the staff resource there to actually deliver this, so it's not an appropriate setting to be working with.
For an organisation involved in a clinical trial, for example, or a search team trying to roll out an intervention and to do a clinical trial, they're really just difficult decisions to have to make, aren't they? Because there's pressure to have to actually get sites to trial your intervention, but at the same time, having to make a decision about the fact that no, you don't have the right environment, context, resources to be able to implement this. I can imagine creates a lot of just conflict for teams, really. I mean, it's a sensible thing to do, but I can imagine there are some difficult discussions happening.
Such is the system in which we try and roll out research. Yeah, but as well, it's a system that trying to roll out research in a very environment that is very resource constrained. And I've always wanted to try and highlight that, because sometimes I think it's not highlighted enough.
So Tom, did you have another case to present to us? That's great. So we've got so maybe about 7 or 8 minutes to do that, and then then we'll have to take questions generally.
Actually, yeah, I've taken a long time to do that, I think. Yeah. Wow. Okay, so this is another case. I'll be very quick. Okay. How do I go forward? Can you am I back on screen? Okay, so this was a project that I did for University of York, because I actually went over, and it's touching on similar themes that we're talking about, because this was a randomized controlled trial that was planned to happen, which was based around community pharmacy, and they were kind of integrating person-centered discussions around alcohol into medicine reviews. But the world changed, the policy context changed. So it was originally targeted at community pharmacists, but the medicine review there was decommissioned because the policy change was to create primary care networks, new organisational forms for GPs, and there would be a new clinical pharmacist workforce introduced. So there's major kind of policy changes, which prompted the question about, how do we adapt the trial for this new workforce? And this research was all about kind of exploring the new context, trying to understand what was happening, and assess the feasibility of our trial. But the new primary care networks were set up in 2019. Really interesting policy, because it's also happening during COVID, or COVID comes later. But there's a lot of pressure there, and thinking about can the RCT go ahead? So I call it in this paper qualitatively driven complex systems analysis, but it's basically the same thing as what I did in the first case. So it's policy implementation research, and I actually did a first logic model of this, because I thought, well, we've got an intervention, we've got primary care networks. That is going to be a mechanism to introduce a new workforce. There's an intervention there, and I was looking at policy documents. Well, what is the logic of what they're planning, what the outcomes that they're aiming to achieve? And I created this logic model based on a review of the policy documents. My manager at the time was quite damning, and quite rightly so, because her response was, well, don't give the policy logic, because it was built on quite hopelessly unrealistic expectations, delivered at very, very great speed, and had conflicting objectives. And these were picked up by Kath Chaplin's analysis quite early on, that and thinking about logic model, or what you're trying to aim to achieve, that basic logic really wasn't there. So on the one hand, they were purportedly hoping to solve the workforce pressures in primary care. That was an objective of the primary care network policy. But on the other hand, they're hoping to transform primary care services by introducing new services. The new workforce, the clinical pharmacists, will be introducing structured medication review, and all of this was happening at great speed. And many of the clinical pharmacists were moving in from community pharmacy, didn't necessarily have much in terms of advanced patient-facing skills and experience. And they would have to be trained. There was a national training package around that. But thinking about the role of existing general practice staff, GPs, potentially that's a lot of time to integrate someone into the role, to equip them with further training and provide supervision and so on. It's kind of rubbing up against that idea that this policy was going to ease workforce pressures in the sector. So there's a lot there to unpick. And also many GPs were quite new to collaborating across organisational boundaries. They had to collaborate with other neighbouring general practices, come together, appoint a clinical director, decide on an operational model. So how the clinical pharmacists would be employed, for example. And some were really cautious around that, because actually employing someone, the life of the policy was only 5 years. So after that 5 years time, if you employed someone directly, then you've got redundancy issues, you're exposed to employment liabilities. And so some were really cautious about that. Others were really pro-pharmacy, and this, no, we're going to seize this opportunity, and we're going to drive it forward, and we're going to accept the risk that it collapses in 5 years' time. So again, this is some of the variation, and it was kind of using the real world logic model approach to understand that variation in outcomes. So we were hitting it 2 years into the policy package. So this was about 2001. And yeah, it was trying to unpick some of the complexity. I absolutely failed on the initial attempt. But this was more kind of grounded and bottom up. But it was kind of working out. And again, going back to Beth's point before, I didn't have the logic model to start with. It was very much grounded in the data and came from it. And the main people we spoke to were senior pharmacists, whose role it was to really kind of lead on integrating the new clinical pharmacist workforce. And what you were getting there was this sense of, well, it's working out in some settings and not working out in others. And actually they were providing these, sometimes they were comparing their PCN with other PCNs that they'd heard through colleagues. Sometimes they were really happy with what's happening, and they provide an account of what good looked like 2 years into the policy in terms of actually integrating the clinical pharmacy role. Others were it wasn't working out. They were frustrated, and they were providing an account of what bad looks like at this point of the policy journey. And this ended up being the basis of that BMJ open paper. So it's more of a kind of like really grounded approach. So I kind of like started to categorize, build into, it was vastly complex qualitative data, but I started to kind of categorize and sort that data in a way that was meaningful to a kind of like logic model approach. So I've got the intervention at the left, I've got the core intervention activities, but I've called that local adaptation, and then I've got the outcome to the right. So the outcome being optimal early role development. And that was really a sense where actually the clinical pharmacists, yeah, they're integrated, they're fulfilled, they're developing in a role. There's a rough balance in their job tasks between more patient-facing responsibilities, gradually taking on quite leading on delivery of certain reviews and clinics, But they are also doing the admin work, which is also taking stuff away, some of the work pressures, existing work pressures, doing discharge letters and stuff like that. But there's a balance there, and they're happy there, and they're kind of supported in the role. But then the suboptimal role development, what that was kind of like, where they're underutilized, right? They're doing basic admin, there's a real excess of basic admin, they're a bit stuck. And the GP and the clinical directors are a bit stuck as well. They're stuck in this rut, and a large part of that was actually, in some places the senior pharmacist wasn't actually established. They weren't actually established yet to actually oversee this and to inform this. So that was a key thing, and that getting stuck on basic admin tasks was key. But then there was also cases of working beyond the competency level, where they're being asked too much, again in the absence of that senior pharmacist to really oversee that role, and that having kind of possible patient safety implications. So there were the kind of outcomes, and obviously all across that data set, there was discussions of staff and service pressures that I've captured up there in the red, and this kind of major policy initiatives implemented at speed. You know, people weren't really able to identify the policy documents. They didn't know the detail. There just wasn't time to read and understand what the expectation was. It was kind of a policy, again, delivered at great speed alongside other major policy developments, integrated care networks, and so people doing this stuff and kind of what's the word, muddling through, if you like, you know, how can we achieve the best we can in a challenging environment, and obviously COVID too. And then you've got the kind of core process where we came in. The primary care network should have been part. So that we were in 2 years into the policy. They should, in theory, that issue should have been part. There should have been a primary care network formed. They should have been decisions around the operational model, whether to employ directly or to procure from a private source. But we found that was still kind of hanging around. Some PCNs had really part to that. They'd progressed. And that was really helpful, because then they could really focus on, well, how are we going to integrate these new clinical pharmacists into the role? But other ones had taken a lot longer to form. They were revisiting the issues. So in some cases, the GPs just didn't know what a pharmacist could add to primary care. And it was a big ask for them to say, well, we're going to employ them directly, take on all this employment liability risk. Now they wanted to try them out, and so they might say, well, we'll appoint one, we'll see how that goes, and then we'll revisit. Okay, we'll definitely go for this type of operational model, and we'll definitely employ X amount because it's worked out really well. And so it was again this kind of thing that wasn't this kind of linear staged implementation progress. There was just a lot of kind of revisiting issues and going back and forth, and there was a lot kind of shaping that. So at the bottom, well, first of all, I've mentioned how critical that senior pharmacist role was, but also the GP. So they're actually providing, where the senior pharmacist was providing advice and support on kind of medicine related issues. The role of the GP to provide a bit more grounding and answer kind of diagnostic related questions. It was identified as being really important to provide a kind of like more of a holistic supervision in terms of its optimal delivery of this policy. But then there was a lot of factors shaping this. One key one at the bottom there being the clinical director view of pharmacy, whether they wanted to embrace it, whether they thought, right, let's go for it, let's get senior pharmacists on board, let's really go for it early on. That was really, really significant. But other factors, the PCN size and space, whether they had space to put loads of new clinical pharmacists and alongside loads of new physiotherapists, alongside loads of new other roles that were being introduced as part of the primary care network, whether they had physical space for all of this affected it. Also GP expectations. There's a lot kind of like shaping this. And again, so this was again a very grounded, emergent logic model, really, that was very much data led, and hopefully managed to kind of capture some of the complexity involved in the primary care network implementation, and account for some of the variation that we were seeing in terms of actually the clinical pharmacists, whether they're integrated, they're really succeeding in the role and look really good candidates for our trial, which was ultimately what this was all about. But other PCNs getting stuck in a bit of a rut and not quite doing it well. So that's another example. So I'm going to actually finish there, I think. So
just before you do finish,
yeah,
I got the timings wrong. So the session's till 12:30, not 12. So you do have more time to yeah.
Okay, well, it's been helpful because I would have rabbited on anyway with that. I can show you some of the data underpinning it, if that is.
I was going to ask if we could hear a bit more, Tom, if that's all right.
Yeah,
Is
sure.
that all right, Beth? Is that okay?
Yeah.
Absolutely. It's me that's confused things, Angela. So please, Tom, carry on as you were.
Yeah, pleasure. So I think I've talked through the basic. Do you have any questions on that, Angela? Well,
I do actually. Sorry.
Yeah, no worries.
Utterly fascinated by all of this. But so if I've understood this correctly, so this model here, it came from the data. You've explained it really well. So am I right in saying that it just gives you a much better oversight as to what's happening in that environment and in that space? And do you then use this model as a way of, I suppose, identifying where other interventions could come in to improve the outputs? Or is that right? Have I understood that right?
Yeah, absolutely. So this is about trying to understand the context, and we had that qualitative data. I see it as basically helping this modeling now. I integrate it into all my qualitative analysis. It kind of helps tell us a coherent story, and this coherent story was around what stage the primary care network is at on the ground. So it's very emergent. We went in, we had no idea. We had to be so pragmatic in terms of the sampling criteria, so open in terms of our questions. We just, COVID was happening as well, and so we had to be so pragmatic. We had this complex data. It was kind of, well, actually, I could tell a story here because there's using this logic modeling approach, and so it's kind of modeling the policy. But then you're absolutely right to say, well, what are the implications of that? So we extrapolated, our audience was kind of policy level. So we extrapolated, we used this to inform our advice to policymakers, right? That you need to really adapt your approach, because some PCNs are really forward. You can't go in with a blanket, well, we're going to, because the next stage along was delivery of the structured medication review, and there's a lot of talk about numbers around that, and that would have been terrible to introduce that as a kind of cross NHS policy, right? Because there's such variation, and actually in those clinical pharmacists who are or PCNs who are stuck in that rut, they're not there yet to do that structured medication review delivery. So it was about developing really quite nuanced, context sensitive policy proposals, and that included sharing learning, doing more to kind of share learning across PCNs. So I think one of the key issues was that senior pharmacist, and some PCNs just didn't have that, or were kind of getting it in externally, but it wasn't sufficient. So that we had advice there on like sharing learning among PCNs, and getting more access, funding senior pharmacists to actually go into PCNs that are really struggling, and so having a really nuanced approach to kind of helping this development to try and nudge that suboptimal examples into the optimal examples. So it's about at the policy level, but I think you might be able to think about training interventions more locally, which was happening. Of course, there was the CPPE training that was going on, but there was a lot around that where it was really working. It was that just the supervision around that, having GP time and the senior pharmacist time. When it really worked, it was both of them, and they were really complementing that national training. So it's something around that, maybe how to really bolster that, because they were providing the training that they were receiving was more academic, or it wasn't necessarily applied. So there was something there about having a senior pharmacist sit in with you while you do a structured medication review, or being able to talk to your GP and having that really quite applied, tailored and approach there. I think that was a bit of a gap that you might think about. Well, what interventions do we need here? Yeah. Does that answer your question, Angela?
Yes, it absolutely does. Thank you so much. Thanks.
But I'll just show you some of the data. So yeah, it's this idea of optimal and suboptimal role development. It just kind of, and that would be the outcome of the model. It just kind of came really just from reflecting on these examples of good development. It was a journey, right? They're still on this journey. We started off quite small, but now they're sort of branching out themselves into their relevant comfort zone. That comfort zone is really important. They are developing, but they're not being thrown into the deep end. And yeah, there's something there, and examples of people actually at the stage of developing their own remote clinics. One in particular, they were struggling initially. She developed a role as a lead for asthma review, COPD. She's done a lot of these remotely. It's been fantastic. So kind of really good. Then some of the suboptimal, excessive administrative work. They're taking on the kind of mop-up jobs, and none of this is being critical of GPs. I'm not being critical. This is more critical of the policy, really, about those tensions in it that Kath Checklin had identified, that there were these competing objectives, and it was being delivered in that context of workforce crisis in primary care. And of course, an absolute rational response is to say, well, we've got all this admin work and we've got new people in. So, and that it's almost it's not even an anticipated consequence. It's kind of a predictable consequence of implementing this policy in that environment. So that suboptimal role development being that excessive admin work, loneliness. So where they haven't got that GP and the senior pharmacist there, that they're quite poorly and supported, and then examples of possible kind of medication related patient safety issues. So this person just saying, we just had a massive issue switching everyone from warfarin to NOACs. Pharmacists didn't really have any training in it, so we're now back on NOACs. We've got people on NOACs that shouldn't be on NOACs. So they were senior pharmacists, and they were covering such a broad area, and they were quite frustrated by the level of influence they'd had over the integration of the new role into the primary care network, and that was a consequence of that they identified. And I've already spoken to this about senior pharmacist role, just hearing what they did, the efforts they did to really integrate and to support people. And then that role of the GP to input into the training, supervision as well. And so yeah, the bottom, it's that those kind of moderating factors. So this is just one of the key ones. So we were first luckily to appoint a clinical director, GP, and we're lucky because they had this really good vision. And he had that good idea of what he wants to achieve. He was able to persuade the practices to pull in their own money to build this pharmacy team. And so what they'd been able to do was really park that first stage because of the pro pharmacy views and the vision. They'd really been able to get this parked and then really get into, like, we've got this pharmacy team. How are we going to integrate them across the practices? What the supervisory support and supervision arrangement's going to be, a lot of team building and stuff like that. It was that was key, but then also other factors, such as, some GP practice were working across boundaries for the very first time. Others were part of established GP federations. They were there, they're really established. They were able just to say, well, our federation is going to be our PCN, and there you've got that issue parked, and you're straight into this. For others, it was, well, this looks to be quite a risky policy because we're not sure about the value added of a clinical pharmacist. We've never had them in primary care before, and we've got to employ them. The policy is only for 5 years. What do we then do after 5 years? So they needed this really gradual of more experimenting, learning about the role, what it could add, what it could add. And I should also say that even though I've got COVID at the top there as a challenge, actually it seems so significant to getting GPs and other practice staff on board with the PCN policy, because many of the clinical pharmacists played a really prominent role in enrolling in the COVID vaccine response, and actually that was key to actually people thinking, you know what, we're going to revisit this, we're going to go back, we're going to move for a direct employment model, because we want to employ them directly because they're so useful. We want that direct management of them capability, and we're going to take more on. And so that was a really key kind of thing that kind of emerges as they're integrating the new clinical pharmacists, but they kind of revisit the PCM because they want to do it more. But all of this takes time, of course. All of this takes time. It's very iterative and exploratory. So that's just another example. And yeah, so I see this approach really is just being a really creative thing of trying to tell a story around an intervention, developing them through primarily qualitative research, really exploring how interventions work in context, focusing on people, relationship, and collective actions, the work in normalization process theory terms, really the work of what is being done. I think sometimes logic models can be more theoretical, that we have this idea of them, but actually what is the intervention looking like in practice? Being really creative in the shapes and arrows to model contingencies and dynamic relationships. And then using these real world models to guide our interventions. So developing nuanced context sensitive facilitation strategies in the first case, whereas talking about facilitators actually really need to adapting their approach to different ward environments. Doing those celebration successes, for example, where staff engagement isn't clear. Before they get onto the really core bit of implementing the toolkit, or of course more nuanced public policy in terms of what I talked about, and the need for quite a nuanced approach around primary care networks to bring the kind of struggling PCNs that are stuck in a rut up to speed with the more advanced PCNs. Yeah, I'll stop sharing. Yeah.
Well, Tom, thank you so much for that. What an amazing introduction to a really useful adaptation of logic models that research teams. I can see so many uses for it, but I'm going to throw the floor open to the people here to see if anyone's got any questions. No, we've had some as we've gone along, but do you have any follow-on questions, comments? Angela.
I'm happy for other people to have questions first. Mine was more of a reflection and I suppose an application. So if other people want to ask a question first, that's absolutely fine, honestly.
I would go with your reflection, Angela.
So thank you so much for that, Tom. That resonated on so many levels for me. So I'm a clinical pharmacist, have been interested and curious as to the intersection between QI and research and how we can use that under the umbrella of healthcare improvement. Currently doing a PhD using realist reviews and realist approach alongside ethnographic, and I've been fascinated. I suppose my core kind of clinical approach as a pharmacist in hospital is looking at implementation of digital systems, and that's what my research is about as well. So I feel like what you've talked about today sort of touches all of that, including the patient engagement and pharmacist roles. But this, I think for me, I'm sort of coming away thinking this would be perfect for my research to help with trying to understand what's going on in the ward environment with digital systems. But equally, thinking also how useful it would be in terms of how we can better implement technology generally in healthcare, and kind of why you sort of find yourself going, why don't we know about this more widely? You know, we could use this to really help us with engaging with staff, improving the culture, really helping in terms of uptake of technology, supporting the kind of change process that goes with that. And I just, a few things that you said have just completely changed my view. So you said this idea of, you know, creating training for staff, and the fact that the implementation staff aren't just taking them through the training, they're shaping the context. I just thought, God, yeah, that's so true. You know, we're kind of teaching staff how to use these digital systems in practice, but they either go with it or they don't. And I don't know, it's just completely shifted, I suppose, how I think and what we might do in the future. So there's a lot going on in my head right now. And I just wanted to say thank you, and applicable on so many levels, both in practice at the hospital, but also with my research. So thank you very much. And are you open to having emails and further conversations, was my question. And if so, would you mind sharing your email address? Is that possible?
Yeah, absolutely. I really enjoy chatting about logic models. Yeah.
Great, thanks.
Yeah, I have an ongoing joke with my partner that I've ended up being a model for a living. It's yeah, always. So I'm always kind of working on logic models, and having that. Yeah, because I think what I'm doing now is quite case study-ish. So really interesting to explore it in that setting, because it sounds really interesting and really quite applied. And yeah, so would be really keen to chat about that further. I think it's really fits with the realist approach as well.
Yeah,
it's about that mechanism, context, and outcome triad. I mean, mechanism can be a little bit abstract for me. I kind of think of in terms of more grounded activities, but understanding them within the context and how your intervention that you're implementing is both kind of shaped and constrained and enabled by the context, but then also proactively thinking about how you go about delivering that and really shaping what you do. I think it's really fits that framework that you're using. And actually the clinical pharmacist route. So Beth, I know your PhD student, Daniel. Yeah, we had a really interesting conversation as well, and I might actually just share his. I've asked Daniel his permission, so he actually used the real world thing, and it was just a really interesting way to go about it, because he fused it with normalization process theory, but again it was sorry, it's not quite working. I've lost my mouse. There. Can you see that?
Yeah.
It's quite small, but if you do it on presenter mode, it might.
Yeah, I'm not going from current slide. It's not. It sometimes always doesn't work, does it? Sometimes I'm clicking on it, so it's a very small. I didn't have time to adapt it. But yeah, he was working alongside pharmacy deprescribing, safety net, and so there's a lot of macro policy here that's trying to obviously shape pharmacy services and roll out deprescribing. So there's a lot of stuff to talk about at that macro level, but then you've also got the kind of organizational readiness, support GP practices he's got there, communication between pharmacy and practice surgery, so that kind of messy meso stuff. But what was interesting, wasn't he developing, he was theorizing what actually deprescribing safety net actually looks like, because there hadn't been much theorization going on. But and tell me if I'm wrong, Beth, but he was also working out what would be required in terms of an implementation strategy for actually this to be implemented correctly. And it's kind of like just really blew my mind, really, because you've got that policy that is trying to implement the stuff, but actually you just kind of unpicked, this is the implementation strategy that you would need to actually implement this in real world settings. And yeah, it was just really interesting. I don't know whether that fits with your approach, Angela, with digital innovations or something. Or
I feel like this is probably, I mean, it feels to me this is something that's missing. So they spend a lot of time doing the whole technical and this whole kind of planned approach to change. And I've been sort of talking quite a lot, certainly for the last 18 months, around we need to really change how we do that, to really try and understand what's going on. And finally, people are starting to recognise that we need to engage people much more throughout the process. But also recognising that we do have these different levels of influences, I suppose, that increases or improves or supports people to really get to grips with digital. And there's all sorts in there. I don't know, it's so multifaceted. It's just, yeah, so I mean, I have some ideas and thinking about how this could really help. I'm sitting here going, this is another PhD. I want to do it, but I can't. But just using this to try and understand a bit more as to what really does support and what doesn't, the successful implementation, I feel I don't know, that just feels like something that's, I don't think it's been done to this extent. But yeah, I feel very excited about it and feel like I need to go and have further conversations. If anybody on the call does know, then that would be helpful.
That's great, isn't it? I'm gonna see if there's any other questions from the group. People have anything they want to ask?
Duncan Smith looks like he's
Duncan looked like, yeah, he was going to ask something.
Just that's my pondering face. It was a brilliant presentation, Tom, and lots to think about. I guess my only thought, which is a bit more of a reflection, rather like Angela. So I'm a critical care nurse by background, and for my PhD, I developed a complex intervention using the theoretical domains framework and behaviour change techniques, targeting registered nurses and healthcare assistants in a ward setting. And I'm in the process of kind of putting together a feasibility study ahead of potentially evaluating that intervention using trial methodology. And I'm thinking about how the process evaluation component of that might contribute to the development of a logic model that captures some of these elements and the particularly the contextual nuance that you mentioned. And I'm not quite certain what that's going to look like, but you've definitely provoked thinking, which is great. And I'm going to read some of the papers. I've already looked at your work, but I'm going to read some of the other things that you've signposted. So thank you very much for prompting thought.
No worries. I'm just going to get back on, because the case I didn't talk about was, how do I get back now? There was another case of an RCT. So this is the RCT, because there's something there about with the participatory research example. It was so the implementation strategy is so fused with what the research team are doing. It's all messy, and but within a trial, you kind of, yeah, you need to kind of make that distinction between the implementation strategy and the actual core intervention. But then also you find with the messy, complex interventions, ward level work, that they're so intertwined as well. So there's something there about unpicking the implementation strategy, because you might have a really good implementation strategy, but your intervention might be faulty. But likewise, you might not be implementing a really good intervention. So it's something about making an analytical distinction between the two, but also thinking of how they're working together and are they complementary. But then, as you say, situating that within a context, and so you've got micro, meso, and macro here, because working out whether there's synergy between the implementation strategy and the intervention, well, that you require that contextual understanding to make those kind of judgments. But yeah, so I didn't go through that case, but that is in a paper I did the journal of evaluation that unpicks its use in a trial, if you're interested.
Yeah, that would be great.
And likewise, I mean, maybe with Angela, maybe we could have a separate session to talk about adapting this approach.
I mean, I can put you in touch with both Angela and Duncan after this session.
Brilliant.
I don't know whether I'm going to give people a quick opportunity to say if they've got anything else that they want to ask. So I'm just looking for hands that haven't gone up. I had a quick question. I guess it relates to, I've been thinking about Angela and the digital technology aspect, and if you're using this approach in a participatory way, so you're developing and adapting your real world logic model as you go. I was just thinking that whenever I've seen logic models, you only ever have positive outcomes on the right hand side, and I wondered whether, as you're going through your participatory approach, some of your outcomes might be negative, and part of your action research really is trying to work out how to make the negative outcomes either disappear or like turn into positive ones. So with Angela's case, I'm thinking about implementation of something like an electronic patient record, which, if you had been doing a participatory approach, you might have discovered that it would result in less face-to-face time with a patient and more time face-to-face with a computer. And actually, for a lot of patients and staff, that would be a negative outcome. But this approach would allow you to look at how you could work to get the perfect logic model for that intervention. That could just be nonsense, Tom. Please feel free to say.
That is my PhD, Beth. So please, Tom.
Yeah, absolutely. You do tend to just have that positive outcome, don't you, in the logic model? And I think how I've set them up is to trying to explain why potentially wards haven't necessarily made it to those positive outcomes, rather than really thinking through potential negatives. So that's yeah. But I guess in the primary care network example, that there was that outcome of the kind of suboptimal, where so that would be a negative, and I've got that contrasted, so that might be an example where, but the point being is that using it really flexibly, and if the story you want to tell is about those negative outcomes, and incorporating that is part of that creative approach of adapting the template. And yeah, I think that would be a really interesting usage of this approach, because there is also sorry.
No, carry on. I'm just thinking that we're coming to past, so we should probably try and draw us to a close and say thank you. But I'll let you finish the point you were going to make.
There's an entire logic modelling approach. I think it's called dark logic modelling, and I've never actually looked at it, but it feels like it would be an interesting one to have a look at and see whether it could be incorporated in the way that you described, Beth.
Brilliant. Thank you very much. Well, I'm sure everybody will join me in saying a big thank you to Tom for spending the time preparing this presentation, and also for taking our questions, and I think giving a really accessible overview into what a lot of people find a difficult area to access. So I think everybody would say thank you very much. And Tom, I'll be putting you in touch with Angela and Duncan after this, and so and I think that, as Sobi has said, the presentation for people who had to leave earlier, and also for people here, if they want to recap anything, will be on the YQSR YouTube channel. And we'll be in touch with everybody about the information about the next seminar when we have that sorted out. Okay, well,
Pleasure.
all right. Thank you, everybody.
Thanks. Bye.
Bye.
Thank you.